Within the word skills, just so you can actually save those to the record before you go to the end.
It's not there.
I started preparation. Are there any questions about that? We'll be posting a safe Medicaid practice before this. We'll try to pick questions that have to do with the content, so renal, dementia, things like that.
What do they do?
The practice assessment is optional. It's just there for you to practice for the assessment. At any time, hopefully you all know, you can make your own AA assessment and practice. When's the module due? I can't remember. For some reason, I was thinking it was like a semester, but and it was yeah, and that would be my part. I heard that one would be the end of the semester. Good to know. Okay. How are you feeling with this so far? We've been able to do the property questions. We would highly encourage just practicing. And you're still learning those test strategy skills that are important. I know a bunch of these are a big chunk. I'm just seeing a class like Peter right on the edge here. And you want to, this next exam is really, really important. Okay? So do your tough use, keep up. You slides with reading, and we have a muddy area that you don't not comfortable with. You can come with me or with whoever that content is. Pretty much the majority of the content. So just glad to meet with anybody via Zoom or in the office. And then the last thing I want to say real quick before we start is I know a lot of you deal with test anxiety. And it's normal to have anxiety every time you testing, but if you feel like it's really affecting your performance, and you feel like you know a lot more to test, the grades that reflect your knowledge level, you know how much you put into studying, you do have to spend that time, obviously, and prepare. But if anxiety is like out of hand, I just want to encourage you to really, really, here to the end, and it's just letting your class look at your time management, how you're using your time, make a schedule, and have blocks of time for certain content, and utilize things like food, and then practice some type of stress management technique. How many of you do something like at least once a week for stress management? So what kind of things do y'all do? Exercising is very good.
I was going to say doing too, so okay.
Anybody do yoga? Anybody do meditation? So meditation is really good. Because if you do it right before you sit down to read or study, because it's going to help you, it'll help you focus, it'll help you stay focused. So it's an exercise in focus, right? So you can come in and we can do a little stress management before the exam. But if you're not practicing it kind of consistently, it's not going to help as much. It's going to be much more beneficial if you're practicing it. So I encourage you to go on YouTube, search for yoga or meditation or something that's going to help you with that. And then just prepare as well as you can. Study practice those techniques and do them right before you sit down. Okay, so we wrapped up neurocognitive disorders on Monday, and then today we're covering different content area, and it's back to like my third content, and it's eyes, ears, and then very little on nose and throat. But nose and throat typically comes bursitis, pharyngitis. But we're going to be focusing today, in this short amount of time that we have, on mostly eye disorders. Look at the slide, you see the majority are on eye disorders and a little bit on eye disorders. So those are the two senses that if you have deficits in, you feel, most people agree that those are the senses you want to preserve, right, and maintain, because those are the senses that help us to best interact with our environment. We feel, when we can't see, it's really dark, and you can't get the lights on, you hear something, it's a safety issue. We need to be able to see, to feel safe. For those with visual deficits often deal with a lot of anxiety in their day-to-day lives because they don't have that safety extra feature that helps them feel safe. I have a sister who has retinitis pigmentosa, or RP, and it's autosomal dominant disorder. Actually, it's all been tested in my family. It is hereditary. There's no blindness in our family. We believe it was a result of a mutation. But she's lost her vision over several decades, and now she's in complete darkness. So she's legally blind. The last slide in the set is her with her sight gone, getting trained on voiceover on her iPhone. There are so many resources for the visually impaired and for those with brain disorders. So we're going to talk a little bit about those. I've also asked her, she's been hospitalized several times for different things over the years, and I've talked to her about what's most important as a nurse, taking care of somebody with visual impairment. So we're going to talk at the end about that. So, I'll log in real quick. Anybody have any family members or close friends who are visually impaired? Macular degeneration. So that, along with diabetic retinopathy, are the leading causes of blindness.
I noticed it, so like it said that I was confused.
So there's, when you say somebody's blind, there's, you can be legally blind and still have vision.
Yeah, my grandpa's like blind, but like, he's progressed like rapidly over the last like 3-4 years, I'd say, and I would say, I hope not, but probably in the next few years, he's gonna be completely blind.
Oh, I didn't.
So it's important to ask your patient the degree of their impairment, because you can be told in reports that your patient is legally blind, and you go in and are reading the papers, okay? So, that's important to know the extent and how it affects their life, right? So, do you want to tell me what the difference are?
Your mom says,
Is it says that it's sent out? All of it?
So most of the time, visual impairment comes from normal age. Right? As we age, we see a decrease in our visual acuity, in our ability to accommodate, go from distance vision to near vision. We tend to be more farsighted as we age. You see people reading from a distance, so that looks better. That you have better distance vision. Then there's all of the different disorders. So for the eye, we're going to be talking about things like glaucoma and macular degeneration, a little bit about diabetic retinopathy. But for the young, so that's for mostly those who are older than age 50, right? So after age 40, you start having changes related to natural aging. For the young, visual impairment most often is a result of maybe occupational exposure or a trauma. So that would be the difference between the two traumatic injuries. Your ear is a sensory organ that has dual function. So what's the other function other than hearing? What else does it help us with? Balance, right. So equilibrium and balance. It's essential for normal development to have adequate hearing. The development of speech and communication. So we do know that those that are hearing impaired might not have clear speech. And so there are specialties within nursing that you can pursue if you are interested in working and focusing on patients with visual impairment. We have a student a few years back that went on to work at Mass Eye and Ear, and she had a focus on this area. And we're looking at that she's doing great up there. I should have her come through the session. So we can become specialized, we can become certified in these areas through the Society of Head and Neck Nurses. So we are teaching patients how to cope and how to adapt to their deficits, right? So, and then the big thing is keeping them safe, right? What they can do within their home to facilitate their senses, and then how to keep them safe in the community is really, really key. All right, so our student learning outcomes. So safety is our first competency. So we're looking at what are the safety risks for common eye ear conditions, retinal detachment. There are some emergent situations that occur with the eye and ear. You can do a trauma, or retinal detachment is considered an emergency and possibly requires surgical intervention. Macular degeneration, glaucoma, Meniere's disease, where you have vertigo. So these people are at risk for injury, falls. They're at risk for crime, right? So they're vulnerable. They're out there vulnerable in this society and are at risk for crime. We're going to assess. We're going to assess and manage patient safety during post-op recovery. So as nurses, if you're working maybe in a surgical center or from SIA, slowly with these types of patients, your focus is on that post-op patient. So helping preoperatively prepare that patient for the procedure, a lot of education, what to expect. You can imagine, I can't even think of like ever having LASIK or anything around their eyes, you know. But so education is critical, and then the post-procedure period. How do they, prevent infection? How do they prevent any complications from whatever procedures they had? All right, patient-centered care. We're assessing and addressing the unique needs of patients. So everybody's different. Everybody comes with different needs. Recognizing the impact on their daily lives, education, and loss, creating individualized care plans for them. Our care should be clear, culturally competent on the diagnosis, the treatment options, and expected outcomes for patients with PEDS conditions, ensuring that they understand how to manage their conditions effectively. It should also be equitable. All patients should have equal opportunity to to all of the procedures. In other countries, especially third world countries, it is not macular degeneration, and it's the leading cause. It's more so things like glaucoma in third world countries. That's a good question, and I will try to think of it. Professionalism, advocating for patients, mental disorders, conditions, making sure that public resources, and looking at your teamwork, we're working with a team, anesthesia, the surgeon, nurses, case managers, and then evidence-based practice. So keeping up on everything. There's so many changes, right, in all areas of medicine. We're constantly learning new technologies, and we have to be up on what's the best treatments, right? All right. So the most common ENT disorders are refractive areas. So if you're over 40, I made it to 50 without requiring glasses. But if you're over 40, most people start needing some corrective lenses to see clearly. Some of the disorders, and the most common is glaucoma, cataracts, macular degeneration, retinitis pigmentosa. I added that because it wasn't in there, and conjunctivitis, and then trauma. Here, hearing loss and Meniere's disease. So that's what we're going to focus on. So the eye is very unusual, and that it's so easily accessible. It's an organ that we can get to very easily. And then that also means that it's also vulnerable to injury. There's nothing protected. We have our eyelids, we have our tears that nourish our eyes, and that when we have something in our eye, it gets diluted and flushed out. We blink. We have reflexes that protect our eyes. It is easily treatable by external exams, unlike most organs. So your eyeball sits in a bony orbit, so it is protected by hard bone around the sides, also connective tissue and a little bit of adipose tissue, and it's surrounded on three sides by our sinuses, so that allows for drainage. We have different glands, and we have different sinuses. So what is it called right here, where the upper and the lower eye meet right here? That's our inner campus, and that's important, a landmark for when we're giving eye drops, right? Because we're applying our eye drops right here. This is our outer campus. We're also applying pressure right here, because when we give an eye drop, our lacrimal glands secrete tears and produce some medication to relieve. So with every blink, your lids wash the cornea and our conjunctiva with tears. And tears are vital to eye health. They are produced in plants in response to reflex or motion. And they're made up of a lipid, aqueous solution, and a mucose solution. And if any three of those are deficient, so if you are lacking tears, the integrity of the cornea can be compromised.
Can you repeat what they were made up of, please? What did you say? It was made up of a
There's
lipid
a-
and then?
There's a lipoid, mucus, and a aqueous solution as part of tears. The sclera is the white of the eye, and it's dense, it's fibrous, it protects the inner eye. It can be slightly blue and very young, dull white in adults, and slightly yellow in the elderly, and it's lined with a conjunctival membrane. And we have our muscles that attach to the eye that allow our visual gaze up and down, that allow us to go to the right, to the left, generally. If you took a cross section of the eye, there are some important components disorders. Your cornea, right here, is transparent, it's dome-like, it's avascular, so it has no vascular supply. It's the most anterior part of the eye, and that is considered the main refractory surface of the eye. So it's what reflects light and allows it to be shot back to the back of the eye near the optic nerve. There's 5 layers to the cornea, and the epithelial cells are completely replaced on the cornea every 7 days. There is an anterior chamber right behind the cornea, and this is filled with something called aqueous humor, which is a liquid, okay? And it drains through a trabecular meshwork with this fluid is produced here and drains through this trabecular meshwork. And it's important because it's a closed system except for that meshwork, that becomes blocked. We have increased pressure in the eye, and we'll talk about the disorders related to that. Your iris, that's the colored part of your pupil. Your iris is right here. It's the colored part of your eye. Whatever color your eyes are, it's highly vascular. And your pupil, which you're real familiar with, you're checking the pupillary responses, that you're looking for dilation and constriction to light. It's important to know, like when we're checking pupillary constriction, that sometimes people's pupils are not equal. Okay, so about 20% of the population, so that doesn't always indicate a problem, and you'll see those patients in the population. And we know that dilation and the constriction is affected by our sympathetic nervous system, like the pupillary constriction, and our parasympathetic nervous system, the dilation. Directly behind the pupil is the lens. So here's your pupil, and here's your lens. It's colorless and transparent. It's avascular. There's no pain or nerve fibers. And the lens, just like in a camera, allows for focus. Okay, so it's going to assist with focus for near vision and refocusing for distant vision, which is accommodation. Right? So it's the lens that is the function is to go from distant to near vision. All the cells formed throughout life are retained in the lens, okay? And that can become quite a lot as we age. And so naturally, you start to develop cloudiness, low vision, and the presence of cataract. So if you live old enough, you start having this build up and end up with cataract. So cataracts are almost considered a normal part of aging. The retina is the innermost surface of the eye. There are 10 layers, and it's nerve tissue. And an extension of the retina is the optic nerve.
10 layers of the retina or 10 layers of the eye?
There are 10 layers of the retina, so it's like tissue paper, very fine tissue paper-like layers. The optic nerve. The retina is an extension of the optic nerve. The macula, you'll see, we talked about this anterior chamber that's filled with aqueous humor. There is a vitreous humor, a fluid that is behind in the posterior part of the eye. And as part of that is something called the macula. The macula is actually considered an area of the retina. Okay? And the macula is important for our central vision. And outside of the macula, the other parts of the retina, that's important for our peripheral vision. Okay? So if we have a problem with the macula, like macular degeneration, are we gonna see central vision? Or, so macula is central vision.
Yeah.
And the other parts of the retina are peripheral vision, like my sister.
I'm just confused because, I thought my degeneration was either your central vision is if you're or your peripheral, you need either or.
It starts with central and it will progress to peripheral, but it starts with central.
Can you repeat the other part of outside the macula?
So, so the macula is part of the retina. The macula is responsible primarily for central vision. The other parts of the retina, like my sister, has retinitis pigmentosa, the peripheral part of the retina, and she's lost her peripheral vision over years. All right. Structural effects of aging. So the majority of patients we see in acute care are the elderly, and so it's important as we go in, we take care of them, that we do everything we can to help preserve the vision that they have. You know, there's normal effects of aging. Those are listed here. We lose that muscle tone, elasticity, and the skin around the eye becomes wrinkled and loose, and you notice that the eye starts sinking deeper into the socket, into the orbit. And it can affect our upward gaze. And so, the cornea changes in transparency and shape. We see thickening and density of that lens as more and more tissue is added to the lens over time. And we see an increased opaqueness and the potential for cataracts. Ciliary muscle atrophy. We lose our ability to go from distance to near vision.
So the eye has like no ability to rid itself of those dead baby cells? It just.
So in the lens specifically, you just get a buildup of that tissue over our lifetime. Yeah, I know it's interesting. All right, and then we notice people age this. We see this gray yellow ring on the periphery of the cornea and the surrounding iris, and that's due to lipid accumulation. Okay? And our ciliary bodies produce less aqueous humor, so there's less nourishing fluid around the eye. Okay, so we're going to talk about first refractive errors. If somebody's hematopic, that means they have normal vision. They have what we consider on this Snellen scale 20/20 vision. So that's considered normal for humans, right? So if I am nearsighted, meaning my near vision is better than my distance vision, I am myopic. If my distance vision is better than my near vision, I'm considered hyperopic. And then there's the term astigmatism. So astigmatism basically is a distortion due to an irregularity of the cornea. So the cornea typically is shaped like a basketball, okay? It's round. With somebody with astigmatism, their cornea becomes misshapen into like the shape of a football, okay? And that affects the lens and how light diffracts within that eye. Okay? So they can cause blurred vision, eye strain, headache. So we use something called a Snellen scale to measure visual acuity. So we can screen people for vision problems, right, starting in grade school, and or sooner if signs of poor vision are evident. And we can use it to measure against, any treatments or, glasses or whatever, devices people are using to see better, is it helping, okay? So with the Snellen scale, the Snellen chart, we, have the patient stand, a certain level, we have our Snellen chart, and we ask them, we just check each eye separately, we ask them to cover their eye, and we ask them to read, the lowest level letters. Okay? And let's say I can read a greater than 50% accuracy, this line right here. Typically 2020 is the fourth line out, is the third. I will be reading this across, and if I get more than 50% correct in each eye, then and that's the lowest, I can't go to this one. That means that I have 20/20 vision. So at 20 feet, I can see and read what the population is, the majority of the population is.
So if you see it like the 2015 or 2010, is that better than 2020?
It is, yeah.
So why do people be like, oh, 2020 is the best?
It's like a blood pressure of 120/80.
I'm trying to be 2010.
I should be reading your mind like
If you have 110/60 blood pressure, yeah, better than 120/80.
In one eye.
Some people have,
Yeah, but we're not, it's not the
superhuman vision.
it's not the right size and whatever.
Birds of prey, like hawks, have like 22, 25 vision. So they can see at 20 feet. Oh, they can see at 20 feet, but we can see at 5. Okay? So they have, I heard they can see a mile away, that's, did you see that?
So where it all says like 20, the first number, is it always 20? Or like
Yes.
is it between eyes? No.
No, you notice it's
Oh, like the distance, right?
Who can tell me what you need to, drive without corrective lenses? What's 20/40, yeah. So, you need 20/40 unless, requires, if you're greater than, if you're 20/40 or greater, you're required to wear corrective glasses and contacts.
That's fine.
Yeah. So, legal blindness, okay? So somebody's standing at 20 feet, and they can only read this, nothing below, it would be labeled considered legally blind. But it's not always just, 200 vision. It could also be loss of peripheral vision, okay? So my sister, with her RP, had fairly clear central vision, but she had lost so much of her peripheral vision, a certain percent of the field, I think it's 30% of the field, she was considered legally blind. But she could read, she could drive up to a certain point, have a certain degree of loss, and we can measure this with the goniometer, the goniometer, like the range of motion. So that's important to understand. When you're walking in the room, you have to look patients with those lines, you're gonna ask. Yes.
What do they do for kids that don't know their
Don't know their, oh, then that's what I have to say.
You don't remember doing that like this? You'd be like, you don't remember doing it?
With kids? Oh, yeah.
I'm old, I guess. I used to do that when I was. They'd be like,
I want to also say, because you might see in something that's maybe you're working in a outpatient place that where we're doing eye surgery. The 2200, if they can't see that what happens next when it's 10 feet, and see if they can read it, and they would have, 10, 200 vision, okay? And then, if they can't do that, then you're gonna see if they can count the fingers directly in front of their face at 3 feet. If they cannot see that, you are going to do hand motion in front of their face. Okay? If they still cannot see that, you're going to say, is there any degree of light? Okay? So if it's purely just light perception, like for my sister, up to a certain point, she could see like the Christmas tree lights, or maybe a street light, and the distance that she could see. So she has some light perception, and now it's advanced where she has no light perception, and where she's in complete darkness 24/7. All right, here are the charts.
And sorry, so with the light perception, so,
So there's some, if you close your eyes right now,
yeah,
I can see there's a bit of light, I'm not complete.
yeah, okay.
Okay, because of these lights.
All right, and then, so if you have perception of light, does that,
You're still legally blind.
okay, all right. That was my
So there are different types of eye charts. If we cannot, for young children, others who can't read the letters aloud, you can use a complete E, and you can have the person, as long as they can understand you, they're going to point to, for example, here, you're going to show each of these individually with each eye, and they're going to point to the direction that these are, the arms of the E are pointing down this way, that way, okay?
Oh, actually, really good.
You remember that?
Yeah, does it make you read like the small?
I don't know.
I was like,
So the cornea and the lens are what are important for focusing light, for our focusing system, for incoming light rays onto the surface of the retina, just like similarly to a camera. Okay? And depending on where that light image lands, I mentioned that it determines whether we are nearsighted or farsighted. Okay? So for those with nearsightedness, light comes in and its focus is in front of the retina. So it should be right here, okay? But it's in front of it. For hyperopia, you see that the focus goes further outside there. So it's that, that is what is considered a refractive area. So for myopia, nearsightedness, your near vision is normal, your distance vision is poor. Your farsightedness, vision beyond 20 feet is normal, but near vision is poor. And then this is an example of astigmatism here at the bottom, where you have that misshaped cornea, more like a football, and it causes visual distortion, blurred vision, headaches, eye strain. So these are all corrected with what's called cylindrical lenses, eyeglasses, right? And the lenses help focus the light rays where they're supposed to be, okay? So that we can have a clear image. So, there are those who, for whatever reason, they don't want to wear glasses, they don't want to wear contacts, and there are procedures that are designed to reduce the need for glasses or contacts. So maybe occupationally motivated, and I believe like pilots, right? They don't only have their life, they lose their glasses or break their glasses, they're in trouble, right? So oftentimes pilots get corrective surgery. Yes.
So, if you have impaired vision, right, and then you get glasses, does that automatically put you at like that 20/20? Or like, where does that put you once you get
So
that correction?
they check you with glasses as well. So they would be a goal. That would be a goal.
I usually get, like, I'm the RP, it's like, I have required, or they just like, quick, but it's just.
Okay. So 20.
I feel like it does depend on where you go in certain.
All right, so these are three procedures, and I'm not going to test you on the details of these procedures. Just know that refractive surgical procedures correct refractive error, but what's important is that you know how to take care of these patients, right? So what are precautions that they should take? And pre-op teaching. So they often create these little videos for patients. And we'll watch one of them. So let's watch the PRK. So this one, they use a laser, and they cure the refractive error by reshaping the cornea that then allows that light to come in and focus on the retina where it should. Okay? Just by reshaping the cornea. And it's not oh.
PRK, or photorefractive keratectomy, is a type of corneal procedure where we correct degrees of nearsightedness, farsightedness, and astigmatism. Patients are a good candidate for PRK if they have a stable prescription in their glasses or contact lenses, they're over the age of 21, and they have an overall normal anatomy of their eye and their cornea. Some patients with thinner cornea may do better with PRK than LASIK, and also patients that have an active lifestyle, like professional athletes, where they really don't want to have a flap in the cornea, they do better with PRK. During PRK surgery, eye drops are used to completely numb your eyes, and an eyelid holder is placed to prevent blinking. Your surgeon removes the surface cells of your cornea, then uses a laser to change its shape so your eye can focus properly. A special contact lens is placed to protect your eye as it heals. It will stay in place for about a week. The process is repeated for your other eye. The surgery typically takes 1 to 2 minutes per eye. You should expect to be in and out of the operating room within 10 minutes. Immediately after the procedure, the vision is significantly better, but it takes weeks to fully stabilize. LASIK and PRK are both corneal procedures where we can correct your vision to get you out of glasses. LASIK has a flap in the cornea, and the treatment is sandwiched in the middle of the cornea. PRK, on the other hand, is a surface ablation, so there's no flap. Working at Duke Eye Center and doing refractive surgery is one of my favorite things to do. We frequently have patients cry immediately after the procedure because they haven't been able to see across the room without correction in a long time. So it really is just life-changing for me and a lot of patients. I love what I do.
So it's pretty amazing. Anybody have this procedure? Anybody have any type of procedure? Refractive procedure?
So it's just for distance? Just for distance?
No. Looking for both. Did you say that?
Yes.
Okay. So it's pretty amazing. They just, so they numb the eye, so the person is awake. So it'd be important to let them know that the eye is numb. It should not be, it should not be pain. That little retractor was a little uncomfortable to me. And and then the fact that they should not take out that contact, leave that in for the week, and then follow up, and they would remove that contact. So that contact is gonna protect the eye.
It'd be so hard not to.
Is there pain after the numbing stuff wears off, or not usually?
It takes 1 to 2 minutes per eye, isn't that amazing? So I would think it'd be worth it all the time.
The contact doesn't dry your eye or anything?
Yeah, I'm sure, so commonly after these procedures, you're on 3 types of drops. And, what else? It's anti-inflammatory, like a fresh day. And artificial tears, that wasn't listed. But, if they have a deficit of tears, I would think that might be a possibility. Right. So if they are known to have, there are people that have dry eyes, right? So those tears help nourish and protect the eye. All right. I want to show this intracorneal ring video as well. So this is another procedure. So after the eye is on the drops, the surgeon marks the eye of the eye, realignment of the corneal left capsule. This will be good for astigmatism. After the eye is in the drops, the surgeon marks the eye to guide realignment of the corneal flap after the laser treatment. Suction ring holds the eye steady while the surgeon creates a thin flap in the cornea. The flap can also be created with a laser for a blade-free LASIK experience. That's complex for other ones. The flap is folded back, but remains attached to the eye by a small uncut hinge, so it's still attached to the ear. A computer-controlled laser beam reshapes the cornea in less than a minute. The corneal flap is repositioned and bonds to the underlying cornea without stitches.
So that one is pretty much just the laser and LASIK combined?
Yes, it's on.
And that would be, would that be the favorable one with somebody who has astigmatism, or anyone, just because I know that they said it was
They use a special laser for astigmatism called an Excimer laser. It's a high-power laser. It sounds like with astigmatism, it's quite in shape and it may require more powerful laser. So LASIK can treat astigmatism. Laser eye surgery requires only topical anesthetic drops and no bandages or stitches are required.
That was what, laser?
Yes.
No stitches and what?
No bandages or stitches. Now, there are recommendations for protection, right, especially while you're sleeping, or when you're out in the sun. So there can be some fluctuating vision for 3 days. And they can give a pain that is uncomfortable in the eyes. They should not rub their eyes for 14 days. They should not drive, avoid water, and swimming
Is that all 14 days?
for 3 weeks.
Driving and water?
Driving, swimming, showering without, should not get their eyes wet. No makeup for 7 days. for all these procedures. Anything in a tube should be replaced with new. So, in the hospital, we do this, we get this little tiny vial of eye ointment. We use it once and we fix it, and we get a new one next time we do. There, you should not leave the eye drop bottle open. Bacteria can get in there. They should wear some type of goggle at night while they sleep. And then one of the side effects that people do complain of with these types of procedures in the more long-term post period are dry eye.
PRK, or photorefractive keratectomy, is
Dark glasses
To be free and flexible, creative, which is really essential to what everyone's made, and I didn't find a platform that didn't.
All right. We are gonna go on to glaucoma, okay? Glaucoma is a group of diseases and is characterized by increased intraocular pressure. So if, when you go to the eye doctor, they are able to measure your intraocular pressure, and a normal intraocular pressure is 10 to 21. We talked about that fluid in the eye, the aqueous humor, right? So that aqueous humor sits in that anterior chamber, and it drains through that trabecular meshwork, right, into the sinuses. And when those pressures become elevated, it can end up damaging the retina, right, and the optic nerve ultimately. And that is what leads to visual loss, okay? The pressure is a balance of the production and then the outflow of that aqueous humor. So you'll see here, the aqueous humor and the fluid, that aqueous humor fluid travels through here. It requires not just a trabecular meshwork that's open and clear, but it also requires an open angle right here, okay? So, this piece right here is called the iris, and it can end up blocking the flow of aqueous humor to get to the trabecular meshwork.
Is that when they call it the open angle?
When you have glaucoma, but you still have increased intraocular pressure, if you have increased intraocular pressure and you have an open angle, that is called open angle glaucoma, okay? If you have a problem and this angle closes, it can happen suddenly. It can be an emergency situation. Then you've got a problem with the outflow of aqueous humor. Okay? So that is called closed angle. And then the next slide goes over that. So.
I have a stupid question. So, back when marijuana stuff was getting like legalized and everybody's like, oh, I have glaucoma. How is that for them?
With marijuana, I have no idea. Anybody know?
No.
What's the picture?
Well, like, would it be the same as like how you're not supposed to smoke? That's a contributing factor for that. Like,
No.
I'm not talking about smoking itself, but like.
Marijuana's supposed to help with glaucoma, they say.
Oh,
If it's a pressure thing, then I understand.
Yeah.
Yeah, people used to get prescribed drugs for it. Huh?
Sorry, I didn't know you wanted to.
I remember.
Well, so if you have closed angle glaucoma and you increase pupillary size, but it's just very inflammatory, you've got a big problem, right? Because you've got that, know where the fluid go, you can now decrease
It reduces the pressure. Your blood, you're relaxed. It reduces your blood pressure.
Marijuana reduces the
It
iron.
reduces it, yep.
Okay,
Oh yeah, my neck is giving it.
all right, so, I'm gonna show this little video.
A clear fluid flows through the anterior segment at the front of the eye, nourishing tissues. At the open angle where the cornea and iris meet, the fluid flows through a spongy meshwork and leaves the eye. But if it passes through too slowly, pressure inside the eye rises to a level that damages the eye, resulting in vision loss due to open angle glaucoma. Untreated, the vision loss progresses from normal vision and no pain to gradual loss of peripheral or side vision, and eventually total vision loss.
So tunnel vision to total vision. And it's very slow and insidious, so people often don't notice it, okay? They call it a thief in the night, right? Kind of like hypertension is silent, so is this, okay? It can just progress very, very slowly. And there's 3 keys of from the slides you had the last night, I bolded this word because this is important, because there'll be a question similar to something like this. Glaucoma is the leading cause of irreversible blindness in the world, okay? It's one of the major causes of blindness in the U.S., along with ARMD, which is macular degeneration, and diabetic retinopathy. Okay, it's important to know these. And glaucoma is one of the leading causes of irreversible blindness in the world. It occurs more often in men than women. Not sure why, I don't know. Increases with age, with family history, and with those who are nearsighted or myopic. There's an increased incidence in African Americans and Asian ancestry, those who've had eye trauma. I had eczema when I was young. I used a corticosteroid cream around my eyes. I have the beginnings of glaucoma. Right? So kind of I've been waiting to hear that because I used corticosteroid cream for years. Diabetes, cardiovascular disease. So,
And is that if you just, for anything topical around your eye, or if you just were on like chronic,
like oral corticosteroids. I have not heard that correlation.
it's more
Yeah.
topical?
All right. So what are signs and symptoms of glaucoma? So they talked about the peripheral vision, so kind of having tunnel vision over time. Patients complain that it's blurred. Halos around lights, so it's nighttime, you're walking down the street, and you've got your street lamps, you've got like halos around those lights. Difficulty focusing and adjusting the eyes and low lighting. And the great thing about glaucoma is that if it's found early on, it can be treated, and visual impairment can be, it can be definitely improved. So you can prevent blindness related to glaucoma by early detection and treatment. And we'll talk about the treatment. They can complain of aching or discomfort around the eyes and headache. So there are 3 P's, and it kind of, so this, I would consider this pain, but the 3 P's that say it's painless. So I think that's in the later stages, like early on, you don't know you have it. Like the only reason I know is something I measure with some reflexive pressure. It's preventable, painless, and it's permanent. Once you have loss of vision, it's gone forever. Okay? Open angle glaucoma is the most common form. It's 90% of open angle. And we talked about all of these things, I'm often unaware, and that aqueous humor can't get through the trabecular meshwork. It's mentioned in the video. It's slow going through it. It's clogged. And, that's also called the canal of Schlemm, where they're right for the trabecular meshwork.
So is primary also called open angle?
It is.
So is primary open angle and primary closed angle?
Correct. Alright. So this is a picture of what the close angle glaucoma is. So, PACG is primary angle close glaucoma. So normally, this eye got an open angle, and the fluid is going to travel to the trabecular meshwork and bring out of the eye. Here, the iris is blocking that outlet. Okay? Now you have increased intraocular pressure. This can be medical or surgical emergency. And you can have a sudden blockage of that anterior angle by the base of the iris. It's considered an acute attack. The patient complains of severe eye, face pain, nausea, vomiting, halo around the eyes, cloudy cornea, and of course people. They can measure that anterior chamber if it is close angle. And if this goes untreated, it can result in blindness.
Sorry, did you say that you would see drainage coming out of the eye?
No, I didn't.
Okay.
So this one's more of a medical emergency,
Yes.
the close? Is
Yeah,
it kind of like a,
slow, insidious, this, you got a sudden closure.
do they have like the shade closing, like retinal detachment or?
No.
No, okay.
And so another difference between the open angle and the closed angle, in the open angle, it's usually both eyes. It develops in both eyes. For closed angle, it's typically one eye, okay? So how do we manage it? So for it's not emergent, you're going for a procedure, we are managing it with medications, okay? The acute situation, that closed angle vision loss can occur within 1 to 2 days if it goes untreated. And we use several different types of medications. So these you're going to need to remember. These are the ones you frequently are giving in acute care settings or if you're working with elderly, right? There are meds called miotics that help constrict the pupil. How's that going to help? It gives more area for the, and it's going to decrease the pressure. Carbonic anhydrase inhibitors, an example of that is acetazolamide. And that's going to decrease production of the aqueous humor. So it's going to decrease the amount of fluid, right? So therefore, decreasing pressure. And then there's beta adrenergic blockers, okay? They're going to constrict the pupils and decrease aqueous humor, and therefore decrease intraocular pressure, okay? These are like beta blockers, just like our beta blockers that we give for high blood pressure, right? But it's in the liquid for the eye axona. This, your aqueous humor. One thing I'm going to say real quick. What class of drug, what are you going to see? What are your last 4 letters going to be for this type of medication? OLOL. Okay, so those are timolol, is a common beta blocker, and beta adrenergic blocker that's given frequently for prevention and to keep pressure down in those with glaucoma. I see that medication, I typically know this patient's got glaucoma. Okay, can it have effects systemically? And what might I expect to see? Cardiac bradycardia, right? So we know our side effects of beta blockers, slows conduction. Now your question? could look that up, and, you could look up each of these classes, and that's sure.
More importantly, is
Right. All right, so this is not curing it, it's, controlling it. So they're going to be taking one or more eye drops several times a day to lower intraocular pressure. Our patients come in the hospital, they get admitted. They're on these medications that are really, really important to preserve their eye health, right? And it's one of the medications, much so in the past. If you're not doing a medication reconciliation, your patient might forget to tell you, like, kind of like their hormones, like their vitamins and medications. They often forget to say that they're on these medications. It's so important to find out and to make sure these meds are ordered and given to your patient while they are in during whatever admission. Make sure you are familiar with the process for giving eye drops. Right? Do we shake the eye drops before we do it? We gently roll it, right? If it's an ointment, how we give an ointment? And that's typically your antibiotics, like photomycin, and that would be in a post-procedure or somebody with an infection. And how do we do it, like toothpaste from inner to outer? And then do we use that one and go to the other eye? If there's an infection in the side? No. So we pitch it, we get a new little tiny vial to the other eye. What are you going to tell that patient? What are they going to expect for their vision after you do a drug, after you do? Yeah, so that's normal. So if they say, oh my gosh, my vision's gone, it's temporary, it's just, it'll hurt. Are we going to irrigate an eye after we give a drop? And are we going to wait a bit of time between eye drops? Yeah. 5 minutes. When we're giving the eye drop, where are we giving it on the center of the eye, the outer canthus, the inner canthus? The inner canthus, you want to make sure you give it a normal size drop, okay? And if the patient can't hold their eye open, you have a glove on, and you're going to hold that eye open to give the drop, otherwise you're going to make the drop. It's kind of like an inhaler when you miss medication. So you're not paying for that medication, you want to make sure you get that medication. Most patients, if their eye drops aren't ordered, they're telling you, because they know how critical their vision is, right? So for closed angle glaucoma, somebody mentioned this earlier, you're not going to get a pupil dilator, a mydriatic, okay? The myotics constrict pupils, and mydriatic dilator, there's an A that helps, do not get a pupil dilator because now you've got this closed area, and if you don't have any way out, and then now all of a sudden you're enlarging the pupil, there's now less space, you get a sudden increase in your intraocular pressure, it could lead to blindness, right? So this is contraindicated, this is it's not on our test or our final, it's going to be on your board, so you want to remember that. Is that accurate?
This is specific to closed angle.
Yes. Yes. Because there's no way out, right? When do we use pupil dilators? We might use them for a procedure or for an exam. So if they have glaucoma on closed angle, that would be contraindicated. All right, so let's talk about surgical images. These are a couple other meds. You can also use like a diuretic, hyperosmotic diuretic. I mentioned that one. That's the XOL. You're going to recognize that as a beta blocker as well. We're going to treat closed happens in one, you're treating both eyes. I'm sure that's evidence-based. You can also do a laser incision in the iris that's causing that closed angle to release blocked aqueous and reduce intraocular pressure. So, preoperatively, we want to know what this patient's baseline is. Sight and sound, what's normal for this patient, what's their baseline. They said retinue brush shampoo or scrub around the eyes if prescribed, no makeup. They can use a pupillary dilation as a pre-anesthetic med, except if they have the closed angle, right? And then a cycloplegic paralyzes the ciliary muscles so that the eyes aren't moving around. That's kind of the last thing that we get somebody's scraping your cornea. Postoperatively, you're not going to check intraocular pressure right away. You're going to wait a couple hours. You're going to use antibiotics. You're going to use ocular steroid drops, like Forte, Dragon's prohibited, an eye patch at night when you're tossing and turning in bed. Dark glasses in the day, typically. Photosensitivity can be a problem. And also help protect. And these glasses have the size. Have you seen people walking around with the size? And so they probably have some type of procedure, right? So anytime photosensitivity is an issue, you see the special glasses. No aspirin. And you're not going to lie on the opposite side. So if I have this procedure on my right side, I can either lie flat. My head of bed should be elevated 30 degrees. And I'm not going to lie with that side dependent. Okay? Report any brow pain, severe eye pain, or nausea, and then signs and symptoms of an infection. So, really important that they know they have to strictly adhere to the medications that are given those drops. Those drops are going to preserve their vision. Loss of peripheral vision, this is interesting, impairs your mobility the most. So if you think about that, if you have tunnel vision, you've lost your peripheral vision, that's going to impair you more than if you've lost your central vision. Family members of those with glaucoma should be assessed twice a year to detect glaucoma early. This, for some reason, this video would not load onto the thing like this. This is just placement of a little shunt that allows for drainage. So this is a drainage point of video. This is the laser iridotomy. So this is where they go in and they make a little incision, otomy, laser irrigate the iris that thing is causing a close angle, and they open it up so that fluid can go through there. The trabeculoplasty laser and the trabeculectomy are related to the trabecular network. So it's going to go in and clean that out so that things can go through that mesh. So if you know your suffixes and your prefixes, you can kind of figure things out. All right, so I've kind of gone over this. Any questions about these? No heavy lifting. You should not bend. You should not bend over. Okay, so if you have to go down, bend at the knees. Avoid sneezing, coughing, vomiting, straining, moving rapidly, bending, or lifting greater than 5 pounds, because that increases our eye pressure. Avoid breathing until cleared, and then in moderation. And then you're going to wear sunglasses beside children out of doors until the cold down. So symptoms to report: new or increased or severe eye pain or pressure, decreased vision, redness, cloudiness, drainage, floaters or light flashes. That can be a sign of retinal detachment, somebody mentioned earlier, and halos around retinal contrast.
When you said not to lay on the operative side, is it only just one? Or can
So
they
if
have
you had
both?
both,
So you just
can't
tell them you have
lay
to
on
lay
your side,
on your
lay
back.
On your back.
What happens if they fall over? I feel like, how do you keep them on your, you know what I mean? Like, I don't know. I think I don't even.
What time is it? Break time? Okay. Is it 9:30?
Yeah.
Really, can you send
Cloudy,
me videos?
upper lens, affordable dock.
I'm uploading them all.
I'm gonna start walking outside,
It's
so.
hazy or cloudiness of the lens.
And if they're strict.
You know, I wish I had done that, I think it's too late now.
But they can't get it done?
Yes. So even though cataracts are considered an age-related eye disease, they are so common among seniors, they can be also classified as normal imaging change. And I mentioned that earlier. Patients often report increased photosensitivity, increased glare, and decreased visual acuity, as you can imagine. So, modern cataract safety. Modern cataract surgery is extremely safe, and it's so effective that 100% of vision lost to cataract formation is usually restored, but it is best to have it done early on before the cataracts have advanced too far. So what are the things that contribute to it? So, nutrition, smoking, obesity are some common risk factors for cataracts. It is the leading cause of disability after arthritis and heart disease in older adults. So this is another one of those disorders where you want to make sure that your patients with cataracts are able to access these procedures. It's going to preserve their vision. Cumulative exposure to UV light, so whether that's occupational, if you sit in front of computer screens, simple life, is a primary risk factor. Also, if you have a history of diabetes, retinitis, infection during personal life.
What kind of infection? Like an eye infection or like a systemic infection? Or is it just a one?
That would be an eye infection. All right, so this is like how it might look for somebody with cataracts. So they're looking at their grandkids and they get this cloudiness and blurred vision. This early decreased color perception as well. The rise in get back to it. And then late, they can complain of double vision or diplopia, reduced visual acuity, progression to blindness. And then you can see that filmy cataract in the people. So there are several surgical procedures. So as soon as like that cataract starts to interfere with their daily life, it's usually time to intervene. So there's these 1 hour procedures that usually take this done outpatient. They are discharged within 30 minutes post-op. And they used to do these with a regional, but now they use topical anesthetics like they did for that LASIK that we saw. The patient's able to communicate and to cooperate, follow instructions during surgery. So typically, they don't do both eyes together, they'll do one eye, and then they'll wait a month, and then they'll schedule the second eye. It gives them some time to recover and to see if it was successful. So there are several procedures. There's an intracapsular procedure that's rarely done that removes both the lens and the lens capsule. The most common is this extracapsular, and they remove the lens in the anterior portion of the lens capsule, not the full lens capsule. They can also use an ultrasound to break up the lens material, and the term for that is phacoemulsification. And then lastly, are a lens replacement, either with glasses, contacts, or an intraocular lens implant. So this is a video, if you'd like to see that procedure. It should not embed in the slide. They would follow the same client education following the eye surgery from slide 20. So that would be appropriate post-procedure instruction for these patients. All right, ARMD. So this, along with diabetic retinopathy in the United States, are the leading causes of blindness. Okay, ARMD. So we have macular degeneration. So remember the macula, what was it part of? It was an area within the retina, okay? And within that macula, we see these tiny yellow spots, and those are called drusen. And these drusen, as they're more and more, it begins to affect central vision, and then works its way out, where total blindness can occur, but total blindness is uncommon. So it's more so blurriness within the central vision. And this is irreversible loss. There are two types of ARMD. ARMD is age-related macular degeneration. So there is a dry ARMD and a wet form. Okay. Dry is non-exudative, or it's dry. It occurs in up to 90% of people with ARMD. It involves the slow breakdown of the layers of the retina with the appearance of the drusen, and those drusen lead to blurred vision. There is no known cure. Studies show that a diet high in lutein, things like spinach are high in lutein, kale and broccoli, omega-3 fish oils, help with preventing. This is something we can do. So heart healthy, cancer prevention type of diet. The dry form can progress to a wet form, also known as exudative or neovascular. So it's very hyperemic, a lot of vascular supply. This is considered a more severe type of macular degeneration. It can have an abrupt onset, and it always follows the dry form. It doesn't always fit. When it happens, it always follows the dry form. You don't always get wet from but if you have wet, it's the downstream. Okay? So there's a proliferation, and that's why they call it neovascular, of abnormal blood vessels growing under the retina within the choroid layer, known as choroidal neovascularization. And these vessels can leak and cause little hemorrhage and fluid flow underneath the retina in the choroid layer. So if the patient were to be looking at this graph called an Amsler grid, it's going to have a specific appearance that's instrumental in diagnosing ARMD. So if you're normally looking at this graph, it looks nice and clear, your lines are nice and straight. And then with macular degeneration in the center, we're going to see blurring and distortion of those straight lines. So diagnostic procedures and tests that they typically do include using this grid, using an ophthalmoscope to look in the eye for that neovascularization, visual acuity or smell and chart, right, because it's affecting our vision. And then there's something called fluorescing angiography, where they can look at those vessels. Okay. is, imaging of the retinal vessels after they inject the dye, so just like other angiographies that we do in other areas. When they have this fluorescent angiography, it can turn their urine green. So that's important to let them know that, so they don't think anything's really wrong. And so it can turn their urine green, so that's something you want to tell them from the dye. So lots of fluids after the dye. And they should also avoid sunlight.
This is a different kind of dye? Is there anything you need to worry about with allergies for this?
Sure, yeah, you all kind of asked about allergies.
What about the same allergies like shellfish?
Not shellfish.
Iodine?
It's not, yeah. I don't know I didn't write down the name of the dye. All right. So, for patients diagnosed with macular degeneration, based on their visual acuity test, they're going to use left corrective glasses, magnifiers, large print, UV absorbing sunglasses, reduced glare light bulbs.
Are those the big sunglasses? Big? Yeah. I would say the old people sunglasses. Yeah.
With the size.
Yeah.
Yeah. So those are for anybody with photosensitivity. It's
Yeah,
just-
I didn't want to say.
It can be treated with laser. You can do laser photocoagulation, where they use a thermal laser to target those new blood vessels, and it shrinks them and it seals leaky vessels. So it addresses that neovascularization. You can use photodynamic therapy. I have the next slide, which is a non-thermal laser, and they use a medication that sticks to the new blood vessels. This medication is injected peripherally through your venous system, and light thermal laser causes the medication to destroy new blood vessels. So this laser treatment is working on that neovascularization. Other therapies include antivascular endothelial growth factor, and then AREDS. Everybody know what AREDS is? So AREDS was an eye disease study. It was a very well-known eye study, age-related eye disease study that classifies different disorders. And there are recommendations from that study on the things that promote eye health. So that study is a combination of things like antioxidants, zinc, vitamin A, vitamin C, vitamin E, that help the body prevent damage and help advance macular degeneration. So this is a little video of the photodynamic therapy. I'm going to have you watch that on your own. And the result of these procedures are to slow or to stabilize vision loss, so it doesn't progress. So healthy foods, high in kale, broccoli, and supplements of vitamin C, E, beta carotene, zinc, lutein, omega-3 fatty acids, and our antioxidants. Maintaining a healthy weight because overweight was a risk factor. Maintaining a normal blood pressure and cholesterol. Activity. Don't smoke. Eye exams biannually. And protecting your eyes with good sunglasses. All right, there's several questions on retinal detachment. And retinal detachment can become it is an emergency. You should seek medical care. And what happens is there's separation of the two innermost layers of the retina, the sensory retina, where the rods and cones are located, and the retinal pigment epithelium, also known as RPE. So two innermost layers of the retina separate. It can be associated with a tear or hole in the retina, and those eye fluids leak. And that bleeding may cause the interior eye. So how's it going to look? You're going to see a hyperemic reddened sclera. It can be caused from trauma. It can be idiopathic. We don't know what causes it. It can be a complication of diabetes or some type of inflammatory disorder. Having a previous eye surgery increases your risk of our retinal detachment. Myopia is increased in factors, an increase in incidence, and then a family history. So how do these patients present? They can have bright flashes of light, especially laterally, peripherally, floaters. So you, in your visual field, you just, when your eyes are closed, you see these little floaters going across your field. Blurred vision, like a cobweb or a hairnet. A shadow, a sensation of like a shade or curtain coming down across one eye. And another term for that is loss of vision of part of your visual field. Okay, so if you can see it described either way. So that it's kind of a loss of vision of part of your visual field. Typically it's painless. And it's diagnosed. So somebody comes in with this, we're trying to do visual acuity. We can use chronoscopes, slit lamp biomicroscopy is a special device that they use. And they use ultrasound as well. The retina appears pale, translucent, and tremulous as the eye moves. So these patients can have significant anxiety due to emergent nature of this, and it can lead to blindness. So time is important. So this would be an example of how the eye might look. It's very important. If they are deemed to be under that category where surgery is not quite indicated, you can do medical management. This can be very, very difficult because it's lengthy and it requires bed rest, which are head dependent, so your head down. And you have this, and that was the worst part, staying in this position, waiting for it to improve. So those innermost layers of the retina become detached and separated. If surgery is indicated, it repairs the detachment with 90% success. And it might take up to 3 months for that vision to return to normal. And it's related to the length of time between detachment and surgery. So that timing is really important. They can use photocoagulation, outpatient and under a local, where they use a light beam through a dilated pupil that creates an inflammatory reaction and scarring of the area. Or they can use cryopaxy, and that's cryo, cold. They use extreme cold to the external globe. Selectively destroys cells that leaves the ocular structures intact. And feel free to watch that video. And then this is another procedure called a scleral buckle. It can also be a local outpatient. And it shortens the sclera. Of course, there's RPE, the choroid in the sclera, close to the retina. So it encircles the band that acts as a splint. So here's your retinal tear, and they put this encircling band to hold it together. And after this procedure, same requirement for the bed rest with the head deep penetrative. This goes over surgical management. Now, retinal detachment can be a complication of other procedures, so it's something we're watching for in that post-op period. The patient should know what to report. And retinal detachment can lead to complications such as increased intraocular pressure, or eye pain could often be reported. Now, there can be failure of that retina to reattach, or repeated detachment. Infection is always a possibility, so antibiotic ophthalmic appointments are indicated. So this post-op intervention is slightly different than the others. So whatever orders you receive for your positioning depending on your procedure. There's another thing they can use where they use a gas and they position the patient to allow this bubble to float up, and it also helps the layers of the retina to adhere to each other. So things that are common with others are no bending of the waist, no heavy lifting. Make sure they're compliant with the medication, warm compresses, use of the eye shield, and readings restricted for at least 3 weeks after retinal detachment intervention. What time is it now? All right. You can go through these next slides. I do want to go to my AHA slides real quick and just go over real quickly.
Are you gonna focus on again?
Yeah, so I did post the other picture for Jonathan. So go ahead and screenshot this. Around there, who wants to be, we're gonna go ahead and start. Just wanna see people showing. Alright, go ahead and start. Signs of retinal detachment, select all that apply. Alright, so the answers are flashing lights and this loss of part of the visual field of the eye that represents that curtain coming down, so you're losing partial vision. That would be correct, right?
So they're not experiencing
No, so it is on that slide, which is a blessing. Yeah. Alright. Match the description on the left, the correct disorder on the right. that's glaucoma, right? We have the open angle, the closed angle. Distorted central vision, that was our macular degeneration, right? Curtain being pulled in with that visual field, you know, that retinal detachment, and thickening of the lens is cataract. So hopefully you all got that, message right. Good job. Post-operative cataract teaching includes the following. Good. Some of you guys caught this 90-day thing here. Good. So no bending to pick up objects, that's going to increase pressure. Sleep on the non-operative side with the head of bed elevated at least 30 degrees, that's correct. Okay. And we've got bilateral, cataracts you don't, but if you've got bilateral, you're lying on your back. Dark glasses at night, does that make sense? No, it should be any day. The eye shield at night, as you're rolling over on your eye. Blurred vision is to be expected initially, and that is true. So it takes a while for your vision to clear.
I took that as like glasses, so it would be specifically for
Like an eye shield would be like that cup shield with the tape that they use. That would be an eye shield. And that's going to protect the eye when you're rolling. I will say, darkened glasses, goggles. Good, good, good. Match the action with the appropriate ophthalmic medication. Okay? You should be able to process of elimination. You don't know one or two of these, figure it out. Let's say I don't know any of these, right? So we talked about reducing intraocular pressure, we're reducing pressure, OLOL, it's a beta blocker. I defined what I know about beta blockers, reducing pressure. So I'm going to pick that one. Inflammation, that's my steroid. Salome, that's a steroid, glucocorticoid, right? I'm going to do that with the reduce inflammation. Then I got these two left. And what this niacin is a antibiotic, right? So that's for treats infection, such as conjunctivitis. And then atropine, which I haven't mentioned, but the process of elimination, you know that this atropine, esophageal atropine, is what they use to dilate the pupil. So this is a mydriatic medication. And would that be contraindicated for any of these specific disorders? So our, what would it be contraindicated when we can study that closed angle glaucoma? The following action regarding administration of eye drops. I don't know if you needed that full time. You guys done? All right, excellent. Okay, we deliver the eye drops to the inner campus, not the outer. We do not irrigate the eyes with a medication. This is normal. It's normal to have blurred vision after you do the drop or the implant. We don't shake it vigorously, we gently roll it. One last one. communication techniques when working with the visually impaired. All right, good. So how can I, tell me a bit about the vision that you have, or if you have no vision. You're gonna ask so you can best help them. Don't feel uncomfortable asking them. They want to share that with you. It's a good thing. Not to pet the guide dog, unfortunately, unless they tell you. Ask the degree of their visual impairment. I see that you're legally blind. Do you have any vision? Do you have just any light vision? So just get information from them. If you are to put their tray in front of them, you're going to describe what's on the tray by using a clock, right? So at midnight, you have your broccoli. At 3 o'clock, you have your chicken. Okay, so you're going to use a clock to tell them what's on their plate. If you're going out the door, you're going to tell them if it's opening inward or outward, and if it's opening from the right or from the left. That helps them when they're going through the door. If it's a narrow passage, they put their hand on your shoulder and follow directly behind you. You're going to ask them, so this is one thing my sister said. She was in the hospital, and they closed her door at night. And she said it gave her a lot of anxiety. She would have preferred the door to be open. Okay? Make sure they have their call light. There is a braille N for the nurse on the call light. You want to point that out to them. A lot of times we see an electrode put over the nurse, right? So they can feel the little electrode button, and they use that to use their call light.
Just kind of just like a side note to vernacular, there's actually, I don't know if you noticed, there's something called, I don't know if it's John Gray or something like that. It's a type of syndrome that causes people with macular degeneration to see people that are not there. So like often, like my grandmother would like see like small people and shapes and stuff like that. So like when my grandmother's driving, it's like a common thing for
There are so many apps and resources for the blind. VoiceOver on your phone. She uses that. The last big picture on the slides is her learning VoiceOver at the Apple Store. It's amazing what